Okay, here we go with immune emergencies for paramedic class. Again, I'm hoping to keep this one down to about an hour. We have 52 slides. When we're talking about immune system, man, there is a lot of A and P and pathophysiology with this one. So the way to study this is go to those chapters. All right, so go back to the A and P chapter. Um, Read through the blood stuff and then the pathophysiology and read through the immune and inflammatory. That'll help give you a good base to start this chapter. This chapter really is pretty short. The very beginning has kind of a superficial thing on the immune system, and it basically farms you back out to chapter 8 to read through that pathology stuff. As far as the content for immunology, it's all about anaphylaxis, right? So if we're just talking about patient care, it's what are we going to do with a mild allergic reaction, a moderate allergic reaction, and then pure anaphylaxis. So that's what you have to kind of gear yourself up for. That's where you're going to get a lot of the questions like, what do you do next? And things of that sort. But be ready for the A&P and the pathology questions too. And so we're going to start with kind of a just definitions. All right. So this is a table that's in your book. You kind of need to know all of these things. All right. This is the basics. It's not too hard. Um, Listen to the lecture and click through the online lecture. If you read through that pathology chapter, you'll have these pretty well. And this is all of these are fairly important as far as quiz questions, and I'll focus on what you really need to know here in this presentation. So what we're going to do is basically go through that list. So the top of it was the granulocytes. All right, so we have basophils, eosinophils, and neutrophils. Those are the different white blood cells that have granules inside, and they each have kind of their own thing. All right, so basophils is what we're going to probably talk about most today, and they are the ones that release histamine. When I think of a basophil, what I want you to know about a basophil is that it is pretty much the same thing as a mast cell. All right, we're going to talk about this in a couple of different white blood cells are this way. When they're in the vessel, working as a white blood cell or cell, they're in the blood vessel, so they're a white blood cell. That they're called a basophil. When it migrates into the tissue, changes a little bit, it is called a mast cell. All right. That is, for the big thing to remember, is filled with histamine, and we'll talk more about it. There's a full slide on it. So eosinophils are going to attack parasites, and then neutrophils are going to attack bacteria. All right. Neutrophils is like the number one blood cell. Most of our white blood cells are neutrophils. The next white blood cell is a monocyte. All right, and again, a monocyte will stay in the blood cell for a few days and then migrate into tissue, just like we talked about with the basophil. When it's in tissue, it's called a macrophage. And these are all about phagocytosis. So they are going to go around. They're like they don't have a great brain. There's nothing there. They can fairly well sense what is self and what is non-self. But these guys just go around, attack bacteria again, and like if there's just cellular debris, something is dead, it'll go up and eat that. When we have pus coming from a wound, when we're coughing up green or yellow sputum, that's the monocyte that probably became a macrophage, and then it did its duty, basically ate up something, and then it pretty much is dead. And that's what pus ends up being, is dead monocytes slash macrophage. And then there's lymphocytes. All right, so these are considered white blood cells also, but they go through a whole different maturation process. All right, so lymphocytes become T cells or B cells. All right, and T cells are going to attack You can see there, attack. They have T's in the word attack. They attack the cells directly. And then B cells create antibodies, and there's that letter B in antibodies, one way to remember that. Here we have across the slide some pictures. Those are T cells, all right? So a T cell has memory. These guys are smarter. So B cells and T cells are smarter than your average monocyte macrophage. And these guys are like what you would consider what you'd consider like reconnaissance, all right? So stay platoon, whatever you would want to call them, LRPs. They're out basically looking around for different things. They have a memory of specific antigens or pathogens, allergens we might talk about. And then they go and a T cell goes in and directly kills it. Different from the other macrophage and the monocytes. They don't engulf it. They go in on the cell wall and basically kill it with chemicals, all right? And then the way we can kind of differentiate this, I called it maturation a little bit ago, the way they mature. And we're going to talk about this a lot more in hematology, but it might be a good way to just start talking about it right now. If you see that blood stem cell, that's in the bone marrow, and you've heard of stem cells, I'm sure, before, and a stem cell is one that when we manipulate it, one way we can do that is through hormones. A stem cell can become anything it wants, all right? And then, or anything it's told to be, anyways. And so when we tell it to become a myeloid stem cell, that's where we get all of our, what we regularly think of as the blood cells, like red blood cells, platelets, and white blood cells. Or they could become a lymphoid stem cell, and then they become a lymphocyte. They could become a B lymphocyte, a T lymphocyte, natural killer cells, and there's helper cells over there. And way over to the right there, I've circled a natural killer cell, and that is yet another one. We can kind of associate that with the T lymphocyte, and you don't really need to know much more. You could call, I'm not going to make you differentiate these two. We don't have like scenarios or anything. But what a natural killer cell does, again, it's going to look a lot like the T cell, is it using antibodies is able to figure out where the infected cell is. So when we have an infected cell, I think the important thing, and the reason that I even included this into this PowerPoint, is an infected cell, when it's inside the cell like that, we're talking about viruses. So far we talked about bacteria, we had parasites in there, so now we're looking at viruses, and the viruses are on the inside of the cell, and that's where they do their damage or their replication and things. So a natural killer cell is able to find this infected cell, and then that goes in and kills it directly. And we can say, again, this isn't phagocytosis, it's killing it from the outside. And then here's that T lymphocyte, and they do about the same thing, all right? The thing with the T lymphocyte is we talk more about memory here, all right? Where that natural killer cell needed an antibody to help with the memory part of it. A T lymphocyte has its own memory. And so we have these immature T lymphocytes, that's over here, up in the upper left corner there, the circle. As it's immature, then it'll come across something that it sees as non-self, that antigen, and it will create, then become a mature T cell. And so that mature T cell could become a helper T cell, or it could become like another killer, direct cytotoxic kind of cell. These help the B lymphocytes also kind of become the B lymphocyte that they want to become, the antibody that they're supposed to become. The immune system protects the body. So we have cellular immunity, that's the T cells. They attack and destroy antigens. You could say that at the cell level, they're going in and killing cells. The humoral immunity is all about the B cells, the lymphocytes, the antibodies, all right? We're mostly going to talk about B cells, all right? So we don't need to know that much about T cells and killer T cells and things of that sort. We need to know they exist, all right? They're all over the place. They're not phagocytosis. They go around killing stuff through basically chemicals. And so we're going to, next is that primary response. We're going to talk about the way we um, adapt to, I guess you would say, our environment. As we bring in different antigens into our body, we look at it and we say, hey, this is non-self. This isn't from within our body, it's from without. And we need to make a decision on what we're going to do about this. So in certain viruses and bacteria, we all do a pretty good job of creating creating a response. So when we first come across this, we can probably just use the flu. We first come across this, the first thing that will happen, like we've never seen this antigen before. The first thing that happens is we just have these monocytes and macrophage going around, and they will say, hey, I'm pretty dumb, but I kind of know what's around, what's supposed to be around, and you don't look familiar, so I'm going to eat you. All right, so it eats it, and from there, we talked about that monocyte dying, and that monocyte or macrophage will then be in the lymph channels. All right, so here, this is kind of important, so pay attention here. So those lymph channels then, we talked about a little bit before when we were talking about edema and filtration. We talk about it a little bit during perfusion. When we have hydrostatic pressure that pushes water out of the vessel into the tissue, and then that oncotic pull that pulls the water back into the venule side of a capillary membrane. We push out more water than we pull back in. And that water needs to get back to the central circulation, and that water does that through the lymph channels. All right, lymph channels are not vessels like our arteries and veins. They are channels. They're basically like open rivers, you might say, where streams is probably a better analogy, where the material that is there is now going up your lymph channels, and up at the tops of our extremities and in our neck we have lymph glands. And so at that lymph gland, that is where some of this work is happening. All right, so lymphocyte, lymph tissue, immune, all of that should be going together in your head. At the lymph glands, we know that when we have a bad infection, we should have learned this maybe in EMT class, but when we have a bad infection, one of the signs of a bad infection is swollen lymph glands. And what's happening there at that lymph gland is they are stopping all of these new monocytes or macrophage that are carrying the cellular debris that is non-self, and it's at the lymph gland that we could picture some like CIA operative that's basically taking pictures, getting his DNA, doing all of that to this terrorist that entered our body. And then we create our T lymphocytes, B lymphocytes, the things that will have memory of this antigen. And at that gland, then we will be saying, hey, let's make those. Remember, T lymphocytes, the T comes from the thymus gland. So the T cells are actually created then, or assisted with, or assisted through the thymus gland, which is again where all of those lymph glands are going to dump into. So we create then these guys that are going to be then doing reconnaissance work. They're going to be out there looking for this antigen the next time it comes into our body. That makes it so in the future, when we come across that same antigen, we won't just have these dumb macrophage or monocytes looking for it and finding it and then kind of having a delayed reaction to it. We'll have a more specific response that'll be quicker and more surgical strike and kill that quicker in a way that we won't get that sick from it. All right. And man, it seems like everybody knows about this now that we went through a pandemic where we had everybody got vaccinations, or let's say much of us got vaccinations, and that then if some people were saying we'll never get the disease, and what ultimately it does is it just helps us fight the disease a little bit more effectively. But the disease still, if it's a virulent disease, still could give you some problems. So this immune chapter is going to really focus on an allergic reaction. I'm going to try and bring you back to immune system and allergic reaction aren't exactly the same thing, right? That it is, the immune system is good. It's there for our protection. And when we're talking about allergic reactions and anaphylaxis, it's kind of like this, something was broken with the system. Something didn't go right. All right. And the parts that we think about then, which there's many different ones, we hardly talk about the autoimmune diseases. We talk more about allergic reactions and anaphylaxis. And so when we're talking about allergic reactions and anaphylaxis, we concentrate on these basophils and mast cells and maybe a little bit more of the B lymphocytes with the antibodies, and then all of the histamines and leukotrienes and such. That discussion, the discussion that we're going to have, is only part of what the immune system really does. All right, the immune system, when we're using all the other antibodies, does fine. It doesn't use mast cells or basophils and histamines and leukotrienes. It kills things you might say, in a more effective way without using the basophils and mast cells. So these basophils and mast cells, again, we talked about them before. A basophil when it's in the blood vessel, and then as it migrates into tissue, we would consider it a mast cell. They both are doing the same thing. They both are going to be filled with histamines and leukotrienes and cytokines and bradykinins and all of that kind of stuff. Most of the time when we address it, it's going to be the mast cell that we're dealing with. But if the basophil in the blood vessel, they are going to also release those same things all over the place when we're talking about anaphylaxis. So here those are. That's what they would look like. They're granulocytes. The basophils are granulocyte. We can see on this picture then we also have neutrophils and eosinophils. The other granulocytes, mast cell as it goes into tissue. Here we have that monocyte. That's the one who became a macrophage as it went into tissue. And separate from there, when we're just talking about immune cells, here's that B cell and T cell. All right. So the B cell makes antibodies. T cells attack. All right. And then up there we have that natural killer cell again. The dendritic cell here, its main function is to process antigen material and present it on the surface to the T cells of the immune system. All right, so I like to just call these guys helper T cells, but that's a whole nother thing. All right, so these guys help the T cells do what they're supposed to be doing. Helps them form the memory. All right, help them form the memory. So when a B cell is in that lymph channel, right? That was in the lymph. When it becomes kind of activated and it's producing those antibodies, then it's called a plasma cell. Hardly very important, all right? But pretty easy to remember. A B cell becomes a plasma cell as it starts to release all of these antibodies. Here we see that antibodies are attaching to that mast cell, and so what I would really like to add to this is these are IgE antibodies. All right, these are IgE antibodies, not IgM or IgA or IgD. It's the IgE antibody that we're dealing with in this picture. And so this is the how things work. All right, over here, up in that upper left-hand corner, we have a red dot there. That's our initial contact. All right, so our initial contact is with just a B cell, and that B cell is going to see this new allergen. All right, again, since we're talking about IgE antibodies, and an allergic reaction, we're going to use the term allergen there. All right. If we weren't in the allergic reaction discussion, this would be called an antigen. It's just a protein. All right. Either way, just a protein. Here, we're going to call it an allergen because as we mature there and we become a plasma cell, we're going to release IgE antibodies. All right. So here we have the release of IgE antibodies, and those IgE antibodies are going to go find a mast cell and stick to the side of a mast cell. All right, so this takes a little while to happen. Once this happens, then the person is like what you'd say is fully sensitized. All right, they are ready to have an allergic reaction. So if this was happening in our nose or in the area around our eyes, the conjunctiva, in our mouth, maybe you'd say, this would then, as we come across this allergy, it would give us a runny nose, saliva, running eyes, or tears. If it's happening in our skin, it's going to give us itchiness and urticaria. If it happens in our lungs, it's going to give us just wheezes. All right. And then if it is happening in a way where we're having a much more systemic response, then it could give us this whole thing of vasodilation and headaches and all of that kind of stuff. So the next time we come across that allergen is going to pop onto one of these mast cells that have the antibodies there. And when that happens, that cell wall will degranulate. And that means it'll be just going away, and all of those chemicals are going to be released. So all those chemicals are now somewhat important. All right. So we're going to go over those. But why our body does this is it will summon the white blood cells to that area. So a lot of what we're going to be seeing here is going to be vasodilation. Maybe lowering our blood pressure is part of that. But we'll see a bunch of vasodilation and increased permeability. And what that allows to happen is our white blood cells can now go into tissue, hopefully specifically where only these mast cells have caused a histamine release. And that is where the white blood cells will actually do what they do. All right, so you increase blood flow to that area, and then you allow the blood cells to leave the vessels to go into the tissue to fight the fight. And so here's all of those chemicals. And again, this is something that's in your book, good note-taking material right here. A histamine causes vasodilation and increased permeability in the blood vessels. It's going to decrease contractility and decreases your coronary blood flow. It then makes you a little bit more prone to dysrhythmias. It will cause bronchoconstriction and pulmonary vasoconstriction. So when it's doing all of those things, the idea of this is like, why would we have this happen in our body? The thought is when we were in a more like this is evolutionary type of stuff, as we were in an environment where if we walked into a place that had bad parasites, virus, whatever it would be, bad pathogens in the air, we would immediately stop breathing all of those things in. Maybe not stop breathing, that might be a little hyperbole, but we would limit how much stuff is getting into our body through our lungs. Other things that are released from mast cells are chemicals, the eosinophil chemotactic factor, that attracts both the eosinophils and the neutrophils. So it's going to pull those out of the blood vessel into the tissue. Here again, remember we're talking about mast cells. Mast cells are in tissue. So these things are all being released in tissue, migrating to the vessel. Arachidonic acid, these factors, though, that's the next ones that we're all going to be talking about. So you don't need to memorize that word. You're never going to see that word again. But prostaglandins, you might. All right. So prostaglandins are smooth muscle contraction guys. All right. Smooth muscle contraction. You have your leukotrienes. This one's more important. Here again, we're going to see a lot of the same things. Vascular permeability, bronchoconstriction, decreased cardiac contraction, decreased coronary blood flow, and dysrhythmias. All right. Here it says it's more potent than histamines, thousands of times, and then it reacts more slowly than histamines. Kind of don't go together, but that all we have to know is leukotrienes, a lot like histamines, react more slowly, stay longer. Platelet activating factor, so platelet aggregation, which is going to cause histamine release, and then serotonin, which is pulmonary vasoconstriction, bronchoconstriction, and then as we keep on going down, we're going to get heparin. We all know what heparin does there. And then cytokines. These mediators trigger inflammatory pathways and increase the recruitment of more inflammatory cells. And then from the kinins, we have bradykinin is one of the strongest kinins and is responsible for increased vascular permeability. It's going to hang around longer. All right. So all of these things, chemokines, cytokines, kinins, all of those, you kind of just need to know the words, the idea that they're released from the mast cell, and they are going to basically allow for the inflammatory process to occur. And that's going to be all about vascular permeability, vascular dilation, and then we're going to have the migration of white blood cells out of the blood vessels. When we get a vaccine, we are basically given something that looks like the bad antigen or pathogen, and our body will then create antibodies for that. When we talk about these different terms, we have acquired immunity and natural immunity. And think of that acquired as I guess you would say a non-natural way. All right. It's basically getting shots. All right. Acquired immunity is getting shots, or I think polio used to be on a sugar pill. Natural immunity is when you just come across the disease and you build your immunity to it. Herd immunity is the idea that most of the group is now immune to this, to that disease or to that pathogen. Active immunity means we actively produced the antibody, and then passive immunity is we just got the antibody. And we talked about this before. If we have to kind of put these words together, active acquired is a vaccine. Active natural is just coming across the disease and creating an antibody. Passive acquired is when we get a shot of antibodies. I think that's called myoclonal, the new way that we fight COVID. It's also discussion with tetanus. And then passive natural would be our mom giving us antibodies. And so here is why we have all of these things. All right. I think we've seen this picture before, and we're going to see it again in hematology. What you need to know is this one, we got a splinter that's entered into our skin here. All right. When that trauma happens, what will happen is damaged tissue will release histamines. All right. You just think of that as we just damaged some mast cells. We traumatized mast cells, and it breaks them apart. And all of those chemicals that we just listed are going to be released from the mast cells. That is going to increase the blood flow to that area. All right, it'll cause vasodilation, it'll cause increased permeability, and and that's going to then bring in the products that we need. Remember, we had that eosinophil attractor. All right, so they're going to attract eosinophils and neutrophils into the tissue to go fight the bacteria that was on the splinter. So as everything leaks, here comes some phagocytosis when those monocytes are now macrophage. We're going to have histamine to allow for everything to come into this area. Platelets will actually start to be activated, and they'll start to cause some clotting to occur while all of this is going on. You see some platelets there in the area right here. So we'll try to seal the wound too. So there is a good side to all of this. Now what will happen then when we got this splinter into our body, we killed the bacteria. If that splinter had something weird on it that we have not been associated with, have not seen before, that monocyte then, I'm sorry, macrophage is probably the best thing to call it there. That macrophage is going to slowly, right, there's two different tracks that it could take. It could go outside the wound and then we have a pussy wound, all right? But before that happens, it should take the lymph channel up to the lymph gland and show that new pathogen to the T cell makers and the T lymphocytes, and then we'll be basically saying, hey, we have a new disease here. We need to make new T lymphocytes, maybe antibodies for that. All of that occurs then through the immune system. And here are the different things here. So when we have an immune response, we could have allergic reactions. It's mostly what we're going to talk about, that and anaphylaxis. And then we have different hypersensitivity problems, and we're just going to brush over what an anaphylactoid reaction is too. So here's something that has little value for us, all right? There's not a lot of questions. It will make some things make sense because we'll see in the neuro chapter, it'll say stuff like, this is a type 2 hypersensitivity or reaction. So I thought I would just include this in this slide. So a type 1 hypersensitivity, type 1 hypersensitivity is IgE mediated. It's quick. And this is how we get anaphylaxis and allergic reactions. All right, so most of what we talk about, most of what we learn in the immune chapter is this type 1. It's the IgE antibody, and then it goes awry, basically. A type 2 is like hemolytic anemia, all right? So these are IgG and IgM antibodies, all right? So this is more about the T cells then, all right? And the T cells killing what they're not supposed to kill. A type 3 and a type 4 are yet different ways that things can go wrong, all right? So we can have T cell mediated ones and immune complex mediated that cause the different diseases that we hit. We do not need to know anything more than there's different types of hypersensitivity that cause different things to come across. Most of the time, then the two big classifications here are, we're talking about allergic reactions and then autoimmune diseases. And so when we create antibodies, we have a couple of different ways that we can create antibodies. Here are the different ones. So we have IgA, IgD, IgE, IgG, IgM. I mentioned these kind of before. So these are located in different areas and they do different stuff. And we don't need to memorize these, all right? All I need you to know is the IgE is the one that's responsible for the allergic reaction. The other ones don't do allergic reactions. There's no discussion of mast cells and all of that. It is the IgE antibody that does that. So when we're dealing with allergic reactions, and now we're maybe up to the nuts and bolts of this lecture, is the idea that we need to know with confidence, hey, this is an allergic reaction. This is what I'm going to do about it. This is a moderate allergic reaction, maybe a little worse. This is what I'm going to do about it. This is anaphylaxis. This is what I'm going to do about it. So a mild allergic reaction basically just has a local reaction, hives, itchiness, something like that, tearing eyes maybe, runny noses. And then the systemic is when something a distance, and usually the key for us for systemic is we have wheezes. We had something happen over here, and now our lungs are dealing with it. All right. Just wheezes all by themselves. I breathed in a bunch of dust, and now I have wheezes, and I have nothing else going on. That still might be considered a mild allergic reaction. All right. It is maybe something that you'd want to treat more aggressively because it's a shortness of breath issue. But if you're dealing with wheezes, only wheezes and let's say runny eyes, no stridor, no low blood pressure, not that uncomfortable, that patient can be taken care of with Benadryl. All right. That's how a lot of people live every day. They have allergies in the spring. They clean out the garage and or the attic or whatever. They maybe are allergic to dogs, and they went and hung out with at a friend's house, and they get wheezes, and they take Benadryl or even Claritin, and that fixes that. They don't need epinephrine. All right. So last thing on this page is there's hypersensitivity, and that's inappropriate allergic symptoms from a substance. And again, the hypersensitivity is kind of maybe a catch-all. All right. And we don't really need to say, oh, if they're hypersensitive, this is our treatment. We're going to stick with 3 different classifications: mild allergic reaction, moderate allergic reaction, and then anaphylaxis. These are all the things that people are allergic to. Pretty easy stuff. Everybody knows this stuff, hopefully. Remember, ingestion. There is another thing that's being, maybe a bigger thing nowadays, is people have different allergies to foods that just give them GI problems, and they're not doing all of what we talk about here. When we're talking about anaphylaxis, then, a lot of times when we're taking care of an anaphylactic patient, there's no exact cause. All right, we just see that they are anaphylactic, and they present with all of these kind of symptoms. All right, so, and that's usually swelling around the eyes, runny nose, swollen lips. Their heart and vasculature includes big old vasodilation, and then that's going to lower your blood pressure for 2 different reasons. The heart can also be a little bit weaker. That in the slide here, you see it say fast or slow heart rate. We can pretty much go with fast heart rate. They're probably going to be responding with a sympathetic nervous system, as long as they are able to anyways. The skin will have hive, itchiness, maybe flushed, all right? And then they could have pelvic pain, and we could call that GI pain, like cramping. They could end up with diarrhea and vomiting. It could go all the way to loss of bladder control. That's not a norm. Lightheadedness, confusion, headache, anxiety, all of those are maybe the H3 receptor sites. Some people could have an anaphylactoid reaction, and that would be the first time they come across something, they have the full-on anaphylaxis look. So they never got stung by a bee. The first time they got stung by a bee, boom, they have anaphylaxis. Could be with shellfish or anything. Something we just need to know a little bit about is that when people have a transplant, they're going to be on immune suppression therapy. The slide is kind of out. I should put this at the end of this end. So when we come across some people that we're thinking is going to be an allergic reaction, we're going to think about scene safety, evaluate what's going on. Remember, not all of the time that a dispatcher tells us we're going to anaphylaxis will it be anaphylaxis. Not all the time that a person thinks they're having an allergic reaction are they having an allergic reaction. They may be super scared because they think they are, because they felt a sting and they figured it was a bee that stung them. Here's the different categories that we talked about: mild, moderate, and severe. And so we'll create a general impression, talk to them a little bit, um, talk about consciousness. When do they think they were uh, subjected to it, to the allergen, or exposed? How about that? Exposed to the allergen. So we have a good timeline. And we're basically going to listen for their upper airway. And this can include putting a stethoscope on their neck. All right. So listening for stridor. Remember, if they're moving only a little bit of air, stridor will be quiet. So listen to their neck with a stethoscope. What I would also advise you to do is listen to a whole bunch of healthy people's necks, so you know what a neck is supposed to sound like and what stridor might sound like. Talk to the patient about hoarseness and tightness or lumps in their throat, and as soon as they start to have that complaint, you should realize that is a indication that they'll need some epinephrine. Check lung sounds early and often. We're listening for wheezes, but then we're also cognizant that it could be hypoventilation, diminished lung sounds, and maybe even a silent chest. We'll look all over the body. Histamine very often is going to give you that, in an anaphylactic reaction, will give you the urticaria in the core of the body, but not everywhere else. So we want to look at their back early, maybe their stomach and chest. We're looking for redness, edema, itching, urticaria. And when we are thinking about treatment, then epi should be on the on the front side. If it's indicated, we'll be giving epi first. That's going to be a big thing that is going to be your questions, all right, for National Registry quizzes and tests is what do you do first? If they're bad enough for epi always comes first. It's not Benadryl and then epi, it's epi and then Benadryl. You can follow that up with some beta agonist inhaler, albuterol that would be, and then maybe Solumedrol following that. So the different types of shock that we're talking about with anaphylactic shock is cardiogenic because it weakens the heart, hypovolemic because they're losing fluid, and then vasogenic because their vessel gets so big. They're losing fluid to what we call third spacing. So all of the symptoms, again, on a table in your book, is warm, flushed, swelling, hives, dyspnea, all of those. We can have wheezes. We can end up with crackles, coughing up some stuff because they can have increased saliva and mucus in their lungs. Hypotension, tachycardia. They could get dysrhythmias. I think that we're dealing with PVCs and such. GI problems, and then central nervous system is going to be confusion and dizziness. That could be because of a low blood pressure, and it could be a H3 receptor site. Management, remember, we're going to scrape that stinger out with a credit card early. All right, early on, that's basic treatment. If it's just a mild allergic reaction, Benadryl will be fine. If it's a little bit worse than that, we're going to put 0.3 milligrams of epi-IM, antihistamines, bronchodilators, and again, the corticosteroids aren't a bad idea. When we get all the way to anaphylaxis, then we have that oxygen, epi, Benadryl, fluids, corticosteroids. You can consider glucagon. That's really for in-hospital. It's a different kind of a different glucagon than we have. It's not that IM preparation, but an IV preparation that is more than we have, like 5 and 10 milligrams of glucagon. The reason for that is it increases the efficiency of cyclic AMP, which makes it so your beta and alpha receptors, when you have epi in those receptor sites, they will work better. I think that's probably the best way to say it. Those are called secondary messengers. intracellular messengers. Hormones are extracellular messages. Cyclic AMP is an intracellular messenger, and it helps the sympathetic nervous system work better. If you don't want to give the person epi, just glucagon at this dosage may be the trick. All right. And that might be some old guy who's already tachycardic, maybe throwing PVCs and things of that sort. And you want to avoid epi. You think you have enough time, you can give glucagon 10 milligrams. And again, that's not pre-hospital. That's in the hospital. That's a special thing. All right. That's not in the drawer, in your crash cart or anything. You're going to have to call the pharmacy, have them mix it or prepare it, I guess you might say, and then it's going to get to you. And then consider vasopressors. So you might want to more carefully give them Benadryl, or I'm sorry, give them epi or dopamine to give them that sympathetic response. And so other information, this is the last of it. From the immune chapter is scleroderma. Is an autoimmune connective tissue disease that causes scar tissue, changes to skin, blood vessels, muscles, and internal organs. It's about all you need to know about scleroderma, all right? And then systemic lupus erythematosus. You can just call that just lupus. That's lupus, all right? And that's a multi-systems autoimmune. It gives you bad kidney and cardiovascular problems. There's some different way to spell African there. So female and African Americans are at the highest chances of getting that. I think Asian is another one. So that's about it. No questions on scleroderma or systemic lupus in your near future, but towards the end, you'll start to see these things pop up in scenarios. All right. The thing is, they're just part of the scenario, big scenario on a written test. But you just have to realize, like, oh, okay, that would mean that they have an autoimmune disease. And how does that impact what we're doing today? And so that's it. I kept this under an hour. We're going to be less than 50 minutes. And I think you got it. Pay attention to that first stuff. It'll start to make, hopefully get it. If you get this really good in your head, hematology is going to be easy because we're going to go over the same kind of stuff in hematology. And things to concentrate for quizzes would be, that front end pathophysiology stuff. Click through your pathophysiology chapter, take those quizzes, and it'll start to make a little bit better sense. All right, thanks.